Hello, good morning. Hi, good morning.
Hello. Hi.
Hi, good morning, Dr. Natasha. Have you joined? Yes. How many people? We'll start in 2-3 minutes, okay? Can we check your slides quickly, Natasha?
Mm,
Just 1 second. Just we'll go through if they're running properly or not.
okay. Okay, 1 second.
Yes. Take your time, it's okay. Share slides.
Yeah, that I have to just put it in setting. 1 second.
Yeah, yeah.
I think my system is not allowing the share screen. Let me try. Is it okay?
It's visible, yes. Just quickly do a slideshow for 2-3 slides.
Yeah.
Yes, please. Okay. So, hello everybody. Good morning. I'm Dr. Gayatri Egbote, and it's my great honor to introduce today's speaker, Dr. Natasha Negalur. She's a senior consultant rheumatologist. She's currently working at Thane, and she's attached to Kim's Hospital Thane, and she's got her own clinic at Synergy Center Thane. She's done her MBBS, MD Medicine, and then she's done DNB Rheumatology, which is a super specialty. She's my great friend and great colleague, and she's going to talk about skin as clues to systemic rheumatic disease. So, skin in rheumatic disease is not always a psoriatic arthritis related skin disorder or probably just lupus related skin disease. So, basically, as I've said earlier as well, rheumatologists are basically internists first, and we have to have some sound knowledge about dermatology, and dermatology colleagues have been of great help to all of us alike. So today she'll be discussing about the role of skin involvement in rheumatic disease. And we all are looking forward to great learning, Dr. Natasha. Over to you.
Thank you very much, Dr. Gayatri. As she said, she is one of my great friends, and we were together in Gurgaon, and she's still someone I look up to, and still get in touch with her when I'm in soup. Okay, so should we start?
Yeah, yeah, we'll start now.
Okay. So skin is the largest sense organ, and it does not only sense the external thing. So it also gives us an idea about what is going inside the body. So today we'll deal with psoriatic arthritis and other. 1 second, I'll just minimize the screen. So, so we'll talk about psoriatic arthritis and other dermatological conditions in rheumatology. When we do a skin examination, we see what is the distribution of the lesions, what is the morphology of the lesion. So we know about a macule, which is a small, less than 1 centimeter flat lesion, and a larger lesion called as a patch. Similarly, a papule, which is a raised lesion, less than 1 centimeter. Larger lesion is called a plaque. Vesicle is a fluid-filled lesion, and larger lesion is called as a bulla. And erosion is a superficial break in continuity of the epidermis, while an ulcer is a deeper lesion, which also may affect the dermis. Other things that we need to see is whether the lesion is photosensitive or not. That is, in response to sunlight, does the lesion worsen or there are new lesions in the uh, when exposed to UV radiation? Are there any mucosal changes, oral ulcers, cheilitis, or are there any nail changes as well? When should you put your antennas up so that there is something more going on? So when the patient also complains of any joint involvement, fever, Raynaud's phenomena is there. There's also associated muscle weakness, or there's a multi-system involvement where you may notice a pedal edema, or patient complains of shortness of breath and you see that there are basal crepitations in the lungs. If there is an inflammatory eye disease or like uveitis or symptoms of inflammatory bowel disease, that's where you need to pay more attention. So let's start with the case. This is a 52-year-old male. He had history of rash below knee since 5 years. He didn't evaluate or get himself treated because it didn't really bother him. But he did consult when he developed swelling and pain of the third PIP and DIP and the left second toe since a month. So this was the rash that he had. So there were erythematous, plaque, scaly, non-itchy, and they worsened in winter, according to him. So this was a classical psoriatic rash. And on the joint examination, he had swelling and tenderness in the PIP and DIP, which is not seen in the image, and also swelling of the second toe. You can see that the whole toe is swollen like a sausage, so that is called as dactylitis. He didn't complain of any other abnormalities, but on detailed examination, there were also nail changes that were found. That was pitting in the nails and onycholysis. So this was a classical psoriatic nail pitting. So the diagnosis of this patient was psoriatic arthritis. Now, psoriatic arthritis is seen in about 20% of patients with psoriasis. Up to 50% of the patients have a first degree relative with either psoriasis or psoriatic arthritis. Generally, they present at an age of 30s and 40s, and males and females are equally affected. The skin involvement, that is psoriasis, precedes arthritis in majority of the cases, 68 to 70%. Both of them come simultaneously in around 15%, and the joint involvement precedes the skin involvement in 15 to 17% of the patients. So regarding the type of psoriasis, the plaque psoriasis is the most common. So these are erythematous plaques and scaly lesions that generally seen on the extensor component like the knees, the elbows, back, scalp. Guttate psoriasis is little less common. They are drop-like erythematous and scaly lesions. Pustular psoriasis mainly comes on the palms and soles, can also be seen on the trunks, and they are pus-filled lesions. Inverse psoriasis generally comes in creases and can be seen in the axilla, under the breast, or in the groin area, and nail psoriasis. When you are suspecting arthritis, which is not a rheumatoid, or you're suspecting seronegative features, then you have to look for psoriasis in hidden areas like the umbilicus, the gluteal clefts, the scalp, behind the ears, and nail changes. So Moll and Wright classified psoriatic arthritis depending on the presentation of the arthritis that was there. So most common is the asymmetric oligoarthritis. It is seen means less than or equal to 4 joints are involved. Most common is the knee. Large joints are more commonly involved. Can be associated with enthesitis and dactylitis, which we will be seeing later. Symmetric polyarthritis, it looks like a rheumatoid joint disease. So hands, wrists, ankles, feet are involved. And what differentiates it from rheumatoid is the DIP involvement. the radial pattern of involvement, that is the MCP, PIP, and DIP of the same finger is preferentially involved. Relative asymmetry, for example, wrist of one hand and the PIPs or MCPs of the other hand may be involved. And rheumatoid factor, anti-CCP antibody are generally negative. Pure DIP involvement, this is a rare type of arthritis where there's only DIP involvement. And nails are commonly involved in this because the nail bed and the DIPs form a unit. So there is a lot of inflammation in the nail bed as well. Arthritis mutilans, as the name suggests, is a mutilating disease, again a rare form of psoriatic arthritis. It is associated with resorption of the bones. Here you can see that the middle phalanx is completely dissolved, and that has led to shortening of the finger here. Another classical deformity seen on X-ray is a penicillin cup deformity. And the telescoping of digits, that is because of osteolysis only. It is also called as the opera glass hand, where in the past, for watching the operas, people used a telescope-like device which could collapse and expand. Similar happens with the digits, that because of the bone loss, the framework is lost and the digits collapse on the skin, leaving loose skin around. Spondylitis and sacroiliitis, the last type of involvement. This is more commonly seen in males, and HLA-B27 is more commonly positive in this. Differences from spondyloarthritis is that it's a more asymmetric involvement. So one sacroiliac joint may be affected more than the other. And the second thing is the osteophyte or the syndesmophytes are not that marginal. It may be a little, it's a non-marginal syndesmophyte and asymmetric involvement. So over the course of time, the presentation of the patients may change. So it's not that helpful in classifying depending on the presentation of the arthritis. There are certain classical features that differentiate this type of arthritis from a rheumatoid arthritis. These are the three things: enthesitis, dactylitis, and nail changes. So what is an enthesis? Enthesis is a attachment of any tendon, ligament, or joint capsule or a fascia to a part of the bone. So this is in case where it's near a joint. So the enthesis is the joint capsule or the ligaments, tendons the inflammation starts at this point and then develops arthritis. Where there is no joint nearby, it can also cause inflammation at that places. So typical is the Achilles tendon, plantar fascia, lateral medial epicondyle, and golfers or tennis elbow, and also in the spine where the ligaments attach. So here this causes inflammation and then subsequent calcification and syndesmophyte formation. In this image, you can see a lot of inflammation in the Achilles tendon and probably also the ankle joint. So this is an example of enthesitis. Dactylitis is called as a sausage digit because the whole digit swells up and it's painful. So here in the hand, you can see, in the feet, you can see these digits. So the inflammation is at all levels in this. That is the joint, the enthesis, where the ligaments attach, the tenosynovitis, where that is the inflammation of the tendons and the synovial sheaths around them, and soft tissue edema. So there's a lot of inflammation that is going on here. Nail changes, typical changes are pitting in the nail, leukonychia, that is white discoloration, crumbling of the whole nail, subungual hypokeratosis, onycholysis, that is separation of the nail from the nail bed, and splinter hemorrhage are some of the common nail changes in psoriasis. In 2006, Casper tried to classify the arthritis into psoriatic arthritis with certain features, that is an inflammatory joint disease with more than or equal to 3 points. So 2 points, so it is a weighted scale. So you get 2 points if you have present psoriasis, 1 if you have a past psoriasis or family history, any nail changes, dactylitis, negative rheumatoid factor, and new bone formation. How to differentiate from rheumatoid are the three things that I discussed earlier: enthesitis, dactylitis, and axial involvement, more commonly associated in a seronegative arthritis like psoriasis. So treatment options, there are multiple treatment options that are available today and starts from the conventional DMARDs Also, biologicals are available, anti-TNF, anti-IL-17 antibodies like secukinumab, IL-20, 12-23 like ustekinumab, IL-23 P19 subunit antibodies, also targeted DMARDs like JAK inhibitors and phosphodiesterase 4 inhibitors like apremilast. So which agent to use? So this is a rough guide. Depending on what is the main domain that is involved, whether it is a peripheral joint involvement is more, or whether the axial joint is predominantly involved, whether the patient only has enthesitis, which is troubling and not responding, or dactylitis, or the other things that psoriasis is main, or the nail disease is more problematic. So depending on these features, along with patient preferences and of course cost, you try to choose which DMARD or which biologicals or which targeted synthetic therapy is beneficial for the patient. So going on to the next case. So this is a 38-year-old female. She came with history of joint pains in the fingers and knees. She had rash over the face, necks and arms, and that she said that it started when she was doing work outdoors. Now, this was the patient. As you can see, she has an erythematous rash on the cheeks. So a typical malar rash, and uh, certain things are known to cause that. So and ANA and anti-DSD-ANA were done, which were positive, along with some other features which were positive, and she was diagnosed as a case of SLE. So when we talk about rash in lupus, it can be classified into three main types. One is a acute rash, subacute, and chronic. So acute cutaneous lupus erythematosus, that is a classical butterfly rash or the malar rash. It is seen over the cheeks and nose, and there is sparing of the nasolabial folds ideally. So these can be erythematous macular papular, and they're usually painful rash. It is a sign that the disease is active. It lasts for days to weeks and does not usually cause permanent scarring. If you see on the hands and the chest also, she has erythematous rashes here, but there is sparing of the knuckles and the joint creases. In the subacute cutaneous lupus, there are two main types of rash. So these are all photosensitive rash, generally occur in the areas which are exposed to sunlight. Uh, One is the annular type, where there is a border which is erythematous and raised, and central clearing is there. And second is like that looks like psoriasis. That means it is a erythematous scaly lesion. They heal. They may cause a little bit of hypopigmentation and depigmentation, and around 50% of these patients meet the criteria for lupus, systemic lupus. A chronic lesion that is called as discoid lupus erythematosus or DLE lesions, they are generally come around the scalp, face, nose area, neck area, ears. So they are coin shaped from where the name comes, like disc shaped lesion, inflamed and scaly, and they generally heal with scarring. So there is a permanent loss of hair or there is a depigmentation, there are scars present. Around 5 to 15% of these patients meet the criteria for lupus. So what are the classical features in any lupus rash? The most of them are photosensitive. That means when in response to sunlight or UV radiation, the rash increases or worsens. They are usually associated with oral ulcers, especially the acute cutaneous lesions. They can be associated with alopecia, either scarring because of DLE or usually non-scarring alopecia. When a biopsy is done, the classical features are interface dermatitis, that is the inflammatory cells in the dermo-epidermal junction. And when seen under a fluorescent microscope, this is called as a lupus band test. That is, the immunofluorescence is seen at the dermo-epidermal junction because of deposition of immunoglobulins and complements. The next case, similar to the previous one. So this was a 58-year-old female. Note her age. She presented with joint pains in the fingers and knees, rash over the face, neck, and arms, which was photosensitive also, and she had generalized weakness. So, this was her presentation in the face and the hands. Similar like lupus, but there are some differences. So, this is a pink to violaceous discoloration, especially over the eyelids, the face, And also note that the nasolabial fold is not spared in this condition. There are papular type lesions on the hands, erythematosus, over the joint creases. Okay, and the interjoint areas are relatively spared. So these are the classical heliotrope rash and the Gottron's papules of dermatomyositis. Further examination showed a proximal muscle weakness, and tests showed a raised CPK muscle enzyme and antibody positive for dermatomyositis. So the diagnosis was dermatomyositis in this case. Other lesions that can be seen, other signs that can be seen is we talked about the Gottron's papules. They are generally seen over the extensor surfaces, over the joints, and can also be seen over the elbows, knees. When there are no papules present, just a erythematous lesion over the same areas, it's called as a Gottron's sign. Also, mechanics hands can be seen. That is a rough or cracked type of skin, which is seen especially in the radial aspect of the fingers. That is called as mechanics hands. A photo-distributed poikiloderma, that is a hyperpigmentation, which is in sun-exposed areas, and it is associated with telangiectasias. So when it is there in the back, it is called as a shawl sign. Neck is the V sign, and on the thigh, it is called as a holster sign, where you holster the gun. One more important finding in dermatomyositis, you may be able to see nail fold, capillary dilatation, and telangiectasias or dropouts, as seen in these minute. Now, it has not been magnified, but still you can see some of the dilated capillaries here. The next case is a 46-year-old female. She presented with pain in the joints and swollen fingers and generalized weakness. So this was how she appeared, and her appearance gave a certain clues. So taut mask-like face with pinched nose and loss of subcutaneous tissue over the cheeks, a small mouth, that is microstomia, with microchilia, that thin lips, and telangiectasias what was seen on the neck. These were her hands, so the sclerodactyly, which not easily pinchable skin, and puffy fingers. So she was a case of scleroderma. The other things that we can see in scleroderma are severe sclerodactyly or thickening of the skin over the fingers that gives rise to contractures and joint pain. Also, the Raynaud's phenomena, which is a triphasic response to cold or stress, in which there is a triple phase, like the initially pallor, followed by hyperemia, followed by erythema and hyperemia. So at least two phases should be there to say that it's Raynaud's. When the Raynaud's becomes severe, or whether arterial involvement becomes severe, it can lead to digital ulcers and formation of pits on the digits. In severe cases, can also lead to calcium deposition called as calcinosis cutis. And when there is critical ischemia, it can also lead to gangrene, which is a medical emergency. Other lesions that can be seen is a salt and pepper skin, where there are hypo and hyperpigmented, so mainly hypopigmented because of loss of melanocytes due to the inflammation of the skin. So there's salt and pepper look, seen usually on the scalp or neck area, back area, ears. And telangiectasias, that is a arteriolar dilatation because of the vascular involvement. So there are certain other common conditions that you may need to refer a rheumatologist for. So this is a typical palpable purpura, that is a palpable or firm purplish or hemorrhagic papules that do not blanch when pressed. And this is the clinical sign of small vessel vasculitis. Note that non-palpable purpura or blanching is generally seen when there is thrombocytopenia. So how do you work up? So there are many causes that cause a palpable purpura. So right from drugs to malignancies to connective tissue disease. So usually a skin biopsy is indicated when there is no clear-cut systemic involvement is there. So what we see on skin biopsy is a leukocytoclastic vasculitis. and whether there is any complement or immunoglobulin deposition. So when the complements are normal or pauci-immune inflammation you see in ANCA-associated vasculitis. IgA deposition generally in HSP or IgA vasculitis. Sometimes you can see palpable purpura due to paraneoplastic conditions as well. In context to rheumatological diseases, Sjogren syndrome is one common cause where we see a palpable purpura. SLE is another. We have to, however, keep a watch for infectious causes, especially bacterial endocarditis or hepatitis B or C. A vasculitic ulcer, these are generally large punched out ulcers that are seen mainly on the limbs but can be seen on the trunk as well. So it is common in vasculitis, especially medium vessel vasculitis, or when the small vessel vasculitis is very severe. Can also be seen in lupus, rheumatoid, mixed connective tissue diseases. One more condition called as pyoderma gangrenosum. So it is very painful condition, and it starts after a trauma, or it's called as a Cobner's phenomena. So some trauma leads to ulcer, which expands quickly and is quite painful. There can be a lot of necrosis. The borders are usually red, violaceous borders with overhanging edges. Uh, it heals with scarring, and on histology, you find a neutrophilic inflammation. So it is classically seen in inflammatory bowel disease, but also can be seen in rheumatoid, lupus, certain malignancies, and certain autoinflammatory syndromes. Livedo reticularis, classic for antiphospholipid syndrome. So this is like a net-like or purplish or a lattice type pattern which is seen below the skin. It's a mottling mostly on the legs, but can be seen on the arms and trunk as well. So this is because of thrombosis of the venules or arterioles, which leads to congestion of the blood in the arterial system. So when you see a skin rash like this, you should be sure to work up for antiphospholipid syndrome. Another common cause of rash is erythema nodosum. These are painful nodules usually seen on the shins of the leg or the ankles. Also rarely can be seen in the upper trunk or the thighs. So these are generally painful bumps, and they resolve in 2 to 6 weeks. And the cause of this is a paniculitis, that is the inflammation of the fat. So it is classically seen in sarcoidosis, but can also be seen in SLE, Behçet's vasculitis, infective conditions like tuberculosis and leprosy too, and certain medications as well. So how do you work up? You may need to do ANA when you are presented with a skin rash which is photosensitive, and you may need to do an ENA profile as well. ANCAs when there's a palpable purpura, multisystemic involvement which is there. Nail fold capilloscopy helps a lot when you, especially in cases of scleroderma, dermatomyositis, or when you are not able to, with just Raynaud's phenomena, with no other systemic findings. Biopsy is helpful in most of the cases. So either a punch biopsy, or sometimes you require an incision or excision biopsy also, especially for deeper lesions where you need to see the fat inflammation in cases of paniculitis, or when you're suspecting a malignant skin lesion. That's it. The deeper biopsy is helpful in such cases. Also, a immunofluorescence study should be done to see for complement or immunoglobulin deposition. So it's a vast universe of skin and rheumat interface. I hope I have brought a little bit of or introduced a bit of rheumatological conditions which have skin lesions. So thank you very much. I think I've done it. I've finished it quickly, I think.
Thank you, Dr. Natasha. It was excellent presentation. As usual, we actually have learned a lot and we got a basic idea about skin in rheumatology. So, I just would like to ask on everybody's behalf. So,
Yes.
we get oral ulcers in many autoimmune or autoinflammatory conditions, right? So, usually whether they, I would like to know, are they always painless or they are painful? What's your take on that?
Yeah. So there are painless ulcers also and painful ulcers also. So painless ulcers generally are seen in SLE, and generally you can see them in the palate or any pedicle lesions which are there. Painful ulcers can be seen in Behçet's disease or inflammatory bowel disease, spondyloarthritis, sometimes even in SLE you come to see. So and associated with lot of lip inflammation and cheilitis. So when that is there, generally painful ulcers are associated. So both the things can be seen to answer your question. Painless ulcers are more commonly seen in lupus and they have to be looked for. I didn't discuss a lot about
And
the,
probably, yeah, that's why,
yeah.
yeah. So that's why probably then generally seen and they're not experienced by patients. And regarding erythroderma nodosum, so for all PGs, it's a very important bedside general physical examination thing, right? And one should not miss it. So
Right.
erythema nodosum, do they come like as a single lesion or they come together? What's your take on that?
So they usually come in crops. So they like a lesion starts usually in the shin area or the ankle area. And when that starts resolving, there is another lesion that comes together with that. So there is a period in which there is a means the lesion coming one after the other. So when there is a there are healing in some lesions and activity in some lesions. So initially it's red and quite painful, and as it heals, it leaves a black or dark pigmentation which is there. So usually comes in crops. Rarely you can also see them as a single lesion, but and when you see,
Okay.
yeah, when so location is also important. So when it usually in the calf area or something, TB is more commonly said to be located in the back posterior aspect of the leg. And so I think the first investigation you should do that when you see a erythema nodosum is a chest X-ray
Chest X-ray for?
or lymph nodes. So lymph node
Okay.
sarcoidosis.
Okay, right. There's one question. In a patient with psoriasis and inflammatory joint pain, what is the single earliest clinical clue that should make us diagnose psoriatic arthritis before radiographic changes appear? Very important question. Yes.
Okay, so psoriasis is already there in a patient. So when there is a single joint, right? Or so it depends on the presentation. So if it's a single joint, it is more likely to be because of psoriasis. If it comes as a polyarticular involvement, so as I said, the pattern of involvement which is there. So in rheumatoid arthritis, generally it's a symmetrical joints are involved. DIP involvement is not that common in rheumatoid. Also, if you see enthesitis, dactylitis that is coming, it's more likely a seronegative feature. So, single earliest clinical clue, I think, is the pattern of involvement that you see. So, DIP should raise your suspicion for psoriatic enthesitis. Dactylitis should raise your suspicion that it is psoriatic arthritis. I think that should answer your question. So, radiographic changes come later on when the because you usually start treatment before and we try to prevent the damage that is there in the radiographic damage is prevented. So I think these seronegative features which are there is a clinical clue that we are dealing probably with a psoriatic arthritis rather than a rheumatoid arthritis. Is there anything you want to add, Dr. Gayatri?
No, no, I think it's fine. So next question is, clinically, what is your preferred method of detecting enthesitis during OPD examination, and which sites do you examine routinely?
Okay. So usually the Achilles tendon, the plantar fascia, the costochondral junctions, the medial lateral epicondyle, or the lateral part of the hip, so these are the places that we usually, the knee, lateral part of the knee. So these are the usual places that tend to get inflamed. So when there's an inflammation, you can see that I showed you the picture of the Achilles tendonitis. So that inflammation can be usually seen. When you're in doubt, that time, especially when you feel that the costochondritis is there, you can get an ultrasound done to see that, for inflammation radiologically. Otherwise, detection, preferred method is clinical examination only.
Yeah, and then you have to correlate that with the
Yes.
history and other physical findings. And
So,
how do you differentiate that from fibromyalgia?
yeah, so fibromyalgia, the points are little different. So also muscular areas are seen. Plus the clinical findings, the history is different in this. So chronic, one is the chronicity for fibromyalgia. So other associated symptoms. Okay, and the tender points are little different. They are mainly trigger points where the muscle or the insertion of the muscles are there. So some of them do coincide with enthesitis points, but I think overall, with the history and the examination should help you differentiate. Duration of illness is one important factor. Other findings for fibromyalgia are if the sleep involvement or the mood changes, forgettability, dyspepsia, migraines, backache. So all these help to differentiate.
And probably raised inflammatory markers.
Inflammatory markers, yeah, ACLP.
Yes. The next question is, how do you clinically differentiate axial psoriatic arthritis from ankylosing spondylitis when imaging findings overlap? Very good question. Yes, Dr.
So
Natasha.
basically, asymmetry, I think that is the only thing that will help you differentiate clinically. The asymmetrical findings plus the findings of psoriasis, like psoriatic nail changes, psoriatic rash. Other things usually help, can be differentiated on imaging only, as far as I'm aware. Clinically is the asymmetrical findings.
Okay, so yeah, it's difficult sometimes to differentiate it unless you have other softer signs like skin involvement or other signs of psoriasis like nail changes, etc., or family history. So otherwise, it's really difficult to differentiate.
Yes.
Yeah. So, Dr. Natasha, could you please go back to your dactylitis image? I mean, in PPT, dactylitis slide. Uh, So our PGs usually, I was earlier a teacher. I mean, I was earlier assistant professor in BJ Medical, Sasun Hospital, and always students would ask. Even we, when we started rheumatology, it was very difficult for us to differentiate between a synovitis, I mean rheumatoid arthritis joint involvement, and dactylitis. So could you please explain in detail what is dactylitis to our PGs alike?
So basically, dactylitis means there is a swelling of the whole joint, whole finger or the whole digit, which is equal. So if you compare this digit with this one or the corresponding digit on the right side, you can see that it is a complete swelling. So there is no. So when you see for a synovitis, generally only the joint area is swollen, like I showed in this slide. Uh, See, so this is a fusiform dilatation. So
Hmm.
a whole finger is not dilated. Here the finger gets narrowed again. So this is a synovitis more likely. And what we see is the full finger swelling is a dactylitis. So generally, all the components here are involved, including the soft tissue. So there's a lot of soft tissue edema. There's a lot of enthesitis because all these attachments are inflamed. There's a lot of synovitis and a lot of tenosynovitis. So even where the tendons have the synovial sheath, where the tendons are attached, there is swelling in all the components of the digit. So the whole digit is swollen because everything in this is swollen. Even the pulleys, this acts as a enthesis actually, because it takes the weight of those ligament of those tendons. So there is a swelling in these pulleys as well. So that's what composes the dactylitis. Whereas an arthritis, for example, you may think this is swollen. So, just a localized swelling on that part of the joint is there. So, generally, when the full finger is swollen or looks like a sausage here, we call it a dactylitis.
Okay. And the commoner, I mean, dactylitis is more commonly associated with psoriatic arthritis, ankylosing
Yeah.
spondylitis
Yes.
arthritis, inflammatory bowel disease, sometimes with sarcoid also. So the next question is, yes, should cardiovascular risk assessment be routinely done in every patient with psoriatic arthritis? And has it changed your long-term management?
So ideally, yes, but I also see the other risk factors like the age of the patient, whether the disease is controlled or no. But usually, psoriasis is associated, especially that which is not controlled well, is associated with cardiovascular morbidity and mortality. So you means it's better to see that the weight is under check, the lipids are okay, sugars are fine, and your obesity or overall disease, first of all, disease activity is under control. So yes, it does, because the phenotype of the patient is also such generally. And you may also get a high uric acid in such cases, both because of psoriasis, because of the metabolic syndrome. So it is definitely ideal to check this in every patient of psoriasis, especially those who are 40, 45 plus, 50 plus. So that should be done.
Yeah. And with NASH, I mean, psoriasis sometimes is associated with NASH. So
Yes.
it's,
Yes.
yes. So next question is, with increasing use of biologics, do you still follow a step-up approach with conventional DMARD in every patient, or are there situations where you would initiate biologic therapy early? So probably he's asking whether when you will go for upfront
Yes.
biologics.
So it
Yes.
depends on what type of presentation it is. So if there's an axial disease and enough, so there are no DMARDs by conventional DMARDs that work that well. So if the NSAIDs do not work very well for axial disease, I would step up to a biological. And suppose if the joints are in peripheral joints are involved, preferentially large joint, oligo or polyarticular, I would try conventional DMARDs first, and then if not responding, would step up to a biological or targeted synthetic DMARD. So it basically depends on what is the main involvement. Suppose enthesitis is involved, so enthesitis is like axial involvement. You will have to step up to you will have to give a biological or a targeted synthetic therapy at the outset.
Yes.
So that's so depending on what is the primary involvement or the main involvement, main domain that is affected, I would choose my therapy that way.
Yeah, and in certain special situations like pregnancy, somebody who's got high inflammatory load and wants to conceive, then
Yes.
probably we go for biologics in certain situations. Yes. Mm, so, what is one clinical pearl you have learned from years of treating psoriatic arthritis that isn't emphasized in textbooks? Many, I think. Yeah.
Yeah, many are there, but one thing I would like to say is that steroids generally, we are told to avoid, but uh, when used judicially, it works well when controlling active disease. So it does cause, it may cause a flare of, skin, but I've not seen it that frequently when you give it along with another DMARD. So that is one thing. And basically the treatment, so a lot depends on the cost of therapy and your choice of medicine, which you plan to step up, depends a lot on how deep your patient's pockets are many a times. So you may not, you may not be able to give secukinumab, even if that is better in those patients because that's a little expensive medicine compared to JAK inhibitors. I
Yeah,
think
yeah,
maybe you are more, you can enlighten
mm,
regarding this.
mm. So as she is absolutely right, but that said, for PGs, Steroids textbook answer is steroids should be avoided in all these conditions like spondyloarthropathy and in psoriatic patients. When, yeah, obviously when we are short of other drugs and when NSAIDs and other things are contraindicated, then short course, yes, maybe. And as she said, absolutely, we live in cost constraint country, so we cannot just follow guidelines which Western people say. We have to look at the socioeconomic status of the patients. So we have to step up or step down our therapy accordingly. Not all our patients afford biologics. So yeah, our DMARDs, the oral DMARDs are poor man's biologics. And nowadays people are using tofacitinib, but yes, tofacitinib, the screening has to be done before you start tofa, and you have to monitor such patients pretty regularly. So there are many clinical pearls, I mean, which are not there in the textbooks, and patients are our textbooks. So I think the most important thing is to see as many patients and discuss with your colleagues or seniors. Uh,
One more thing is the use of other DMARDs like leflunomide, uh,
yeah,
and means leflunomide basically it also works well, very well in fact in peripheral arthritis. So that is not generally, methotrexate is one thing that is usually highlighted in the studies, but not the other DMARDs conventional,
yeah.
uratimod also.
Right, right. And especially coming back to steroids, when somebody's got uveitis or inflammatory bowel disease, in such conditions, yeah, you may go for steroids. Right. I think it was excellent session, Dr. Natasha. We've learned a lot,
Yeah.
and we'll ask MRA people when this will be available on YouTube channel. So we're looking forward to have another lecture with you. Thank you so much.
Thank you a lot. Thank you so much,
Thank
MRA and Dr. Gayatri, for giving me this chance today.
you. No, thank
Okay.
yes, yes. Thank you. Bye. Take care.